Welcome to In a Heartbeat, coming to you today from Henry Ford Hospital at the Pearson Clinic Center here in Grosse Pointe Farms. I'm Dr. David Bali, and I'm your host of In a Heartbeat. Today, I'm very excited and honored to have as my special guest, Dr. Jadranka Dragovic, and she is Division Head of Radiation Oncology at Henry Ford Hospital and Medical Center. Dr. Dragovic, thank you so much for being our guest today.
Thank you, Dr. Bali, for inviting me. I'm very honored to be on the show. I am, as you said, a radiation oncologist. I'm the medical director of the radiation oncology at the Cottage Hospital, or rather Cottage Medical Center of Henry Ford Radiation Oncology Department. I have been in that role since about 2000, and I have been with the Henry Ford system since 1985, so 30 years this year, which is very exciting for me. I am certified in radiation oncology. What radiation oncologist does is treats breast cancer and other cancers with radiation. So I'm not a diagnostic radiologist, but as an oncologist, I have to know all the related fields that touch upon my own specialty.
And today we're going to be focusing on breast cancer, but just out of curiosity, what are some of the other things that you treat with radiation oncology?
I treat prostate cancer, lung cancer, colorectal cancer, skin cancers, lymphomas, I mean practically all adult malignancies, not the pediatric ones though.
And as our local residents know, the Cottage Hospital is right next door here to the Pearson Clinic where we're doing our filming today. And so, in general, what are some of the other services that are offered at the Cottage Hospital in Grosse Pointe?
Cottage Hospital is no longer a hospital. It is a medical center, which means there's no in-hospital beds in the hospital. But what is offered are ambulatory services. So there's surgical ambulatory services. There's the diagnostic radiology department, the radiation oncology department. There is physical therapy. And as of recently, I think they're just about finished with the construction of the American House, which will be on top of on the top floors of the Cottage Medical Center.
So Dr. Dragovic, aside from skin cancer, which is the most common cancer amongst women, breast cancer really is the most common type of cancer. And it's more common than the combined cancer of breast cancer, than colon cancer, prostate cancer, and lung cancer combined. So it's something that I think women probably, in some degree, think about not uncommonly in the back of their mind or have a concern about, especially if there's a family history of that. And one of the diagnostic tools that is available that has been a standard is a mammogram. And maybe just kind of, for somebody who may not exactly know what a mammogram is, what is a mammogram technically, and what is the process that a woman goes through when she has a mammogram?
Well, to start off, breast cancer, as you said, is a very common cancer. 1 in 8 women will be diagnosed with breast cancer in the U.S., so you can see the magnitude of the problem with that. With the routine use of screening mammography, over the past 2 decades, the mortality rate of breast cancer has decreased, and it is thought to be directly related to the early detection. So the decrease in the death rate of women from breast cancer is an important benchmark or milestone, and women are urged to do the breast screening. The mammograms are basically x-rays of the breast, and the old technology, which is the film screening technology, can be likened to a photograph. The currently used digital mammography are images that are stored in the computer, so you can kind of equate that to keeping your photographs on your computer. And the advantages of the digital mammography is the fact that you can look at those images on the computer, you can enlarge it and look at the more detailed architectural changes, you can darken it, lighten it, enhance it, so that the accuracy is much greater than with film mammography. Also,
so you can almost like Photoshop it or move it around or enhance it like
and
you could on your
right.
iPhone.
You can
or
then
personal.
focus on areas that maybe look a little fuzzy, different on a regular mammogram, but on a digital mammogram they will be more
And
enhanced.
they're available everywhere throughout your system. You don't really need to have the film itself.
No, you don't. They're all there stored on the computer, and what is nice about it is that they are read right away, and if a woman is part of the Henry Ford health system and has a medical and is enrolled in the MyChart feature of the electronic medical record, she can get those results within an hour.
That's amazing. That's amazing.
It still takes several days to get the letter, but if you have MyChart, you just click on the computer and you can see your own report.
That's a wonderful advancement. You know, the recommendations for mammography, I think, have been in a little bit of a state of flux, and that sometimes may create a little bit of a confusion in a patient's mind. And so, Dr. Dragovich, what would you say are your recommendations for mammography for women?
Well, the Henry Ford health system still follows the ACS guidelines. The ACS stands for American Cancer Society guidelines, and those are very clearly stated. Starting at age 40, women should start having yearly screening mammography, and it continues throughout the woman's life as long as she's in good health. In other words, let's say you're 88 and you're still very healthy and active, you would still have a mammogram. However, you may be 75, but you're very sick from various other conditions. In that situation, you may not be able to undergo treatment for breast cancer, so what would be the point of discovering it? So as long as the woman is healthy, it is every year, starting at the age of 40. In addition to that, what is recommended is to have a clinical breast exam, meaning a physician does your breast exam, periodically recommended every 3 years for women in their 20s and 30s, and yearly for women in their 40s. But the currently new recommendations that have been put forward by this task force that is called the U.S. Preventive Task Force, that's a group of health experts convened by the Department of Health Services, Human Services, or I can't remember the exact name. But in any case, they have come up from their review of the available data that the screening should be started at age 50, not 40, that it should stop at age 74. That is the one that really surprises me. Why 74? And that it should be done every 2 years, not every year, and that women should be discouraged from doing self-breast exams because they're totally useless. There has been an outcry from various societies about these recommendations, and there's obviously a lot of controversy about them. The American College of Radiology has called these measures, quote, cost-cutting and dangerous. They say that all the decrease in the mortality that we have achieved over the past 2 decades may be reversed, and it can cost us women's lives. So presently, the American Cancer Society still goes with their own guidelines, and we're still following them. Whether the new guidelines will be accepted by the Congress as part of the new Health Act is yet to be seen, and then one has to look at, what will that mean for insurance payments and so forth.
My take on it, and please give me your thought or input, is it doesn't sound like it was made. These decisions were, proposals were perhaps made by concerned physicians who have the best interest of the patient in mind. It was more the cost of it and how to eliminate costs as opposed to what's in the best interest of the patient.
Exactly. It's looking at the large picture and the big, the large population-based decisions.
But say cut off both ends of the age spectrum and do it half as much. You cut the cost, but it doesn't really, it doesn't service the patient well?
If we have determined that early detection is important, then it should be, you should strive to do early detection. Of course, these guidelines would not apply to women that are at very high risk, and they would just be for an average risk for breast cancer women.
Dr. Dragovich, have you ever run across a patient, I'm curious as to what you might say, say for example, there's a woman who's listening to this who probably falls into that category of needing a mammogram based upon guidelines, but doesn't want to because she's afraid for some reason or another. She may be afraid of discomfort, afraid of maybe finding out something she's afraid of hearing about. What would you say to her?
Well, there really is nothing to be afraid of. Yes, mammogram is an X-ray. There is some radiation associated with the mammogram. It is a radiation, it is an X-ray. The amount of radiation that one gets from a mammogram is equivalent to about the amount that one gets from background radiation that we're all experiencing for 3 months. So it's very low dose, so it's safe. There has never been any evidence that mammograms will cause a cancer in the breast or induce it. The pain situation, it is an uncomfortable exam. It is not a terribly painful exam. There's many more painful exams than a mammogram. It does squeeze your breast. There's some tools that can be used that can minimize that pain, the so-called mammopads. They're little soft inserts that are placed between the plastic what are they called, the plates, and it is not a big deal. Mm-hmm. So I would say the benefits are much more overwhelming the potential detriments. What could be the potential detriments is the fact that, yes, mammograms are not 100% accurate. So there are situations where you can get a falsely positive result. What that means is there is no cancer in the breast, but something was seen, and then you're anxious about what is it, the physician is anxious about what is it, you undergo a biopsy, so it may be an unnecessary intervention done as a result of finding something that really is not there. But that happens rarely, and it is, as I said, strongly overweighed by the benefits of finding actual cancer when it's very early. And nowadays we find it when it's, teeny, 0.5 centimeters,
which is
as
a great
opposed to
advancement.
a lump that you can feel, where the tumor is usually by then 2 to 3 centimeters in diameter and may have spread already to the lymph nodes, and from there can spread to the bloodstream.
What are the options for a younger woman in their, say, 20s or 30s who may have a family history of breast cancer, are concerned about it, or just are concerned in general?
The ones that are concerned in general, if they have no high risk factors for breast cancer, mammography is not a way to go, because the incidence of breast cancer in women in 20s and 30s is very low, so the yield of screening mammography is going to be very low, and the harm may be greater than the good. But what can be done is the regular clinical breast exams by a physician every 3 years, and to some extent, breast self-exam may be useful, although it has not been shown to decrease the mortality of breast cancer in itself, but it empowers the woman to have control over her health and body, and obviously if something abnormal is there, one should obviously report it to the physician. This, of course, is a different situation for a woman that has that is at high risk, and we can talk about that if you want, the high risk factors.
You led me into my next question. So what are the risk factors for breast cancer?
Well, the two biggest risk factors are being a woman and aging. So putting aside those, because you have no control over that, there are a number of risk factors that have been identified that are associated with increased breast cancer. And you can categorize them broadly into 3 categories. The factors that contribute to a 4 times or greater risk. That's called a relative risk. So that means 4 times greater than an average woman. These would be women that have the genetic alterations such as BRCA1 and BRCA2 gene malformations. Second would be women with 2 or more first-degree relatives. So let's say a woman has a mother who's had breast cancer and a sister who's had breast cancer. She's at a very high risk. Also, women that have had positive biopsies of hyperplasia, atypical hyperplasia of the breast would fall into that category as well. The next category would be 2 to 4 times. Those would be women with only 1 first-degree relative, women that have high concentration of endogenous estrogen in their body, and also women who have had radiation to their chests, often as adolescents for another cancer, like women that with Hodgkin's disease that have been treated in the past with radiation and are cured of Hodgkin's disease as a result of that, but because their breast tissue was irradiated at an early young age when the breast tissue is still developing, they're at a much higher risk of breast cancer. And then the third group is where the risk is 1 to 2 times greater than an average woman, and that's a hodgepodge of things. A lot of it boils down to the estrogen levels in the body continuously. So things like early menarche, late menopause, having no full-term pregnancies or delaying the first pregnancy to a late age, no breastfeeding, hormone replacement therapy with progesterone and estrogen combinations for menopausal symptoms, being overweight or gaining weight in the postmenopause, having a personal history of ovarian or colon or uterine cancer. And there's a number of other factors that have, in some studies, shown to be associated, in others that are not.
Dr. Dragovich, are there any dietary or environmental factors that you think are important or noteworthy?
Yes. The dietary factors, it's very difficult to prove a cause and effect thing. There was a very large study, the Nurses' Health Study, that enrolled some 95,000 women, and they looked at the high-fat intake while on study and showed no correlation. But what they did show was that women that had a high-fat diet in their adolescence had a much higher rate of breast cancer. Associated with that is this postmenopausal weight gain. Women that gain weight after menopause, and particularly if they gain a lot of weight and become obese, the risk can be as high as 1.5 to 2 times greater than the regular
That's
risk.
significant.
If you look at the various racial groups, like Asian women have a much lower incidence of breast cancer. It is thought that it is the diet that they have, which is different from the Western diet. Yet when they come to live in the United States, already by the next generation, the breast cancer rates increases, and by the 3rd generation, it is back to the same level as the population in the U.S. Also, what's been shown is that a decreased level of vitamin D may be associated with an increased risk. Things like the parabens in nail polish or cosmetics, some plastics, also the certain chemicals like DES, women that were exposed to diethylstilbestrol when they were younger may have a high risk for breast cancer. The women that work in night shifts, for example, where the diurnal melatonin metabolism is affected, may also have a high risk. So there's a lot of different things that can
Has there
affect.
any thought to, you know, people like to have, you know, nice green lawns and things like that, fertilizers and so bug sprays and things like that to keep yards green and neat and tidy?
That's a big can of worms, because it is very hard to determine causation for such things. However, there are some studies that have shown that women in higher socioeconomic status areas have a higher risk for breast cancer, and that may be multifactorial. It may be the fact that the hormones are affected by better life, earlier menarche, more hormone replacement therapy, but they also have lawns, they're more likely to use more cleaning products, and that has been looked at, and there is a association, however, not a cause and effect relationship that can be proved. The other thing is that often things that have occurred in the past, when these women now that are getting breast cancer, when they were growing up, when they were adolescents, when their breast tissue was at highest risk, the exposure at that time may have created what is happening now and causing an increased effect. There is certainly a known fact that certain chemicals have a estrogen mimicking effect. So they basically react in your body the same way as increased estrogen does, and we know that increased endogenous estrogen in the body will be a promoter for breast cancer. So these chemicals attach to the receptors on the breast tissue the same way that estrogen does, and through a series of chemical and biochemical reactions will cause DNA damage.
And looking a little bit on the brighter side of things, having breast cancer isn't necessarily have the negative outcomes that we often associate with it, and there have been many advances in terms of research and treatment. Can you please speak to some of those things?
Oh, absolutely. There have been major advances made in all aspects of breast cancer management, in the detection, in the diagnosis, in the treatment. We've already touched upon the detection, digital mammography. Also, I should mention the MRIs, because for younger women that have high risk for breast cancer, it's recommended actually to, in addition to mammography, have MRIs, because they're much more capable of detecting architectural changes in the denser breast tissue that is often seen in younger women. But aside from that, there's in the realm of surgery, for example, most women are now getting breast conserving treatment, not mastectomies, so that cosmetic results are much better. The women that do get mastectomies have many more choices in reconstructive surgery that has really advanced very much. In the radiation realm, there have been advances that allow better targeting of radiation, lower doses to normal tissues, more tissue sparing, also more focused radiation with so-called partial breast irradiation. In the medical oncology realm, newer drugs, better supportive care, lower toxicity. There's also newer anti-estrogen therapies that are used as so-called chemoprevention, so that high-risk women can be put on these products and decrease their rate of breast cancer. So yes, certainly breast cancer is no longer considered a death sentence if you diagnose it early, treat it properly. Most of these women live to normal lives. I have patients that I'm following, 20 years later, and they're still doing
Isn't that wonderful?
Well. However, they do have a higher risk of incidence of the breast in the opposite, of breast cancer in the opposite breast. So what I'm seeing is, 10 years later or 15 years later, everything is fine with the breast that was treated, but now she has developed a new breast cancer on the other side. So women with breast cancer need to continue follow-up with routine mammography and clinical exams.
I will even say in the patients that I see, the women who have breast cancer, I think there are brighter outlooks. The treatments don't seem to be as devastating, whether it's a radiation treatment or a chemotherapy type of treatment. There are happier outcomes. There's more that can be done in terms of supportive care, reconstructive surgery, and it just does seem to be moving forward in a positive direction.
And what is really important now is once you achieve a high cure rate, the pendulum starts to kind of shift back, and you're now aiming at keeping the same cure rates but trying to minimize the treatment, so trying to minimize the side effects. We all have seen women that have been treated 30 years ago that either have had a mastectomy, a radical mastectomy where their chest looks excavated, or have had radiation that has caused a lot of skin scarring. Nowadays, with the new technology, that does not happen, and we've scaled down on treatments and still have the high cure rates.
Dr. Dragovich, say for example, a woman is watching you speak right now and says, you know what, I just want to get my mammogram right now. Do you take walk-in patients?
Oh, absolutely. As I said, I'm a radiation oncologist. I do not work in the diagnostic radiology department, but
at Cottage Person Clinic.
I will relate my personal experience. Last week, I decided to go and schedule my mammogram, which was supposed to have been done in July, and I just didn't have time for it. So I went to the receptionist, and I talked to one of the therapists there, and asked some questions regarding the hours, because I knew I would be talking to you. And I said, and by the way, I want to make an appointment. They said, oh, come on in. I had my mammogram right there and then, and an hour later I had my result. So yes, the walk-ins are welcome. The cottage mammography department works, I think, on a daily basis, Monday through Friday from 7:15 to 2:45. And then they have some late hours on Mondays that go from 6 to 10 p.m. There's hours on the Saturdays and Sundays. So there really is no reason why anyone claiming that they don't have the time cannot do it. And they do take walk-ins. Tuesdays and Thursdays they do diagnostic mammography, so those days are a little more busy and maybe more difficult to get a walk-in squeezed in, but otherwise, yes.
Well, readily
absolutely.
available. And we don't have a lot of time, just actually a matter of seconds, but self-exams, self-breast exams are still very important.
They are important, although they have not been shown statistically to have an impact on either early detection or mortality. However, it's a good practice to do it. A woman needs to be taught how to do it properly, and especially for the younger women, it needs to be done consistently on a monthly basis, 2 to 3 days after their period has stopped.
Well, Dr. Dragovich, you've been a pleasure. Thank you for all the wealth of wonderful information. And October is Breast Cancer Awareness Month, as we all know.
Yes.
Thank you to our viewers as well. As always, it's great that you tune into us. We appreciate your time. Take good care of yourself and those around you, and have a great day.